Hi, everyone. I'm Angela Love-Zaranka, Program Director for Lactation Education Resources. Sekeita?
Yes, I'm Sekeita Lewis-Johnson, Accredited Provider Program Director here at LER, and welcome to this final exam review. We're so delighted that you are joining us today. It is jam-packed, so, Angela, take it away and let's find out what's in store.
That's great. Well, first, just a little bit about ourselves. So I am a board certified lactation consultant. I've been board certified for over 25 years. I've been working in the community for 30 years and doing community breastfeeding support. I also have served on the IBLCE board of directors. And so I am familiar with some of the processes. Granted, it's been a minute since I was on the board of directors, but at least I'm a little bit familiar with it. How about you, Sekeita?
Yeah, I am a nurse, a lactation consultant, and a birth doula. I've been in IBCLC for about 15 years, working in the hospital setting as well as in the community setting. Yeah, I'm also a nurse educator, so I bring that lens and that background. And I also recertify this year, not by exam though, but anyways, I've sat for the exam twice. So there's
So you
that.
know.
So, yeah,
Yes, yes.
absolutely.
So today, Sakita and I are going to be reviewing a few key concepts in different areas of the detailed content outline. Now, the topics that we're going to present today are based on the candidate's performance, and we chose the ones where people have the most challenges. We're going to have a chance for you to test your skills with 14 multiple choice questions, and then we're going to review a few test-taking strategies with an emphasis on what you can do for yourself before, during, and after the exam. Okay, so if you have any questions for us today and you're using a laptop or a desktop, you can take a look at the GoToWebinar panel here. See that blue arrow? It's pointing to the area where you will find the questions box. The GoToWebinar doesn't have a separate chat function, but you're welcome to chat in, for example, where you're participating or where you're listening to us today. Go ahead and type that into the questions box. We'd love to know where in the world you are located. If you are participating today from your mobile device, use the question button here at the bottom, and you can ask us questions or type in where you are listening from today. Now, we have a wonderful support team here as well. We have Jill, who is our tech support person. So if you're having any tech issues, feel free to go ahead and type it into the questions box and Jill can help out. We also have Julie on the call today. So Julie is a member of our wonderful customer support team. She is also one of our instructors, and she is an IBCLC. So they have taken the exam recently. Actually, I think Julie has probably taken the exam the most recently of all the IBCLCs we have on staff. And so she is here to answer your questions either in the chat. She'll flag a couple of them for us to answer near the end. So without further delay, let's also remind you that please don't photograph or record the information with a camera, phone, or other equipment. We
I'm
are recording this.
sorry. I'm sorry, Angela.
Yes.
Your slides are not advancing. And so,
And there we go. How's this?
okay,
Is it now?
thank you. Absolutely. There you go.
Thank you. So then let me show you. Thanks so much, Sekeita. So let me show you where those question marks are. So there's one here for your desktop and laptop, and then you have one here if you're participating on a mobile device. So thanks so much, Sekeita. Now, a few of the questions are going to be answered during the session, as I said, by Julie, and other ones they're going to flag for later on in the presentation. So and just as an FYI, sometimes this lecture does go a wee bit long. So if y'all have to hop off, remember that we are recording it. Okay, so now we're going to begin with medications. Sekeita, I think you're up, right?
Yes, I am. Thank you, Angela. So we have a jam-packed session for you, and I realize when I'm feeling like, oh, it's jam-packed, I speak fast. So I'm going to intentionally try to slow down a little bit, but if I speed up, just let me know if I need to read or go over some things. So let's start with medications. Really, you want to know the key points, but before I talk about the key points, I want you to understand that this is a practice exam. So yes, there's some information here, but you also want every single slide that we go over, you want to think about how is it applied in practice? So, because you may not just get a straightforward question, for instance, like what is the milk to plasma ratio? I mean, you might, but you want to know the actual concepts and how they apply to practice. So just wanted to just put that out there. But medication key points, just remember that the amount of medication that enters into milk, that's excreted into milk, it depends on many factors. So one is the milk to plasma ratio, which I just talked about. It's useful to evaluate the relative concentration of medication in the plasma compared to the milk. And when I say plasma, I'm talking about the lactating person's blood plasma, right? And so if it's a high ratio, that means it enters easily. Another key point or another characteristic of safety when we're thinking about medications is the relative infant dose. It is an important clinical parameter regarding, is it really safe? And so it's usually expressed as a percentage of the maternal or lactating person's dose. So, according to Hale in Mother's Milk and Medications, mother's milk medications with a relative infant dose less than 10% is considered relatively safe for a full-term infant. So, if it's greater than 10% for a full-term infant, there should be cause for concern and further assessment. Now, notice I said full-term infant. You want to keep that in mind because for any preterm infants, this rule does not apply. All right. Oral bioavailability refers to the ability of the drug to reach circulation after it has been ingested. So, drugs with low oral bioavailability are generally poorly absorbed in the GI tract, okay? And that's the infant's GI tract. And they are destroyed by the gut. I'm really trying to slow down, but I guess I'm going too fast. They are destroyed by the gut and taken up by the liver prior to entering the infant's circulation. So those are some key things. Other key things to keep in mind about medications is that they can only enter the milk compartment only from, again, the lactating person's blood. Also remember that during the colostrum phase, medications transfer into milk a little bit easier than in mature milk. However, the total dose that will be transferred to the infant is low due to the low milk volumes of colostrum. So keep that in mind. So additional key points is that most drugs enter milk at clinically insignificant levels, right? So in order to determine safety, you determine the levels in the milk, the relative infant dose, and the lactation risk category. You also want to be cautious of high vitamin doses and avoid high doses of medications that are sedatives, opioids, radioactive agents, anti-cancer agents, and high doses of iodine. I'm going to just, oh no, we're going to talk about, sorry, drugs may transfer into milk if. So this is the slide that sometimes people have um, some questions about, but just listen closely and then you'll see, because that last bullet point throws people for a minute. But drugs may transfer into milk if they have high concentrations in the maternal plasma, if they have low molecular weights, less than 800 Daltons, low protein binding, passes into the brain easily. So, in essence, I'm going to flip this and say you want to choose medications that have short half-lives, high protein binding, low oral bioavailability, or high molecular weights. I believe that this will be in your handouts, so don't fret, you will get it. All right. So breaking down the medications by classes. One of the things before I start to talk about this slide is I did list the L categories. Please don't try to remember the L category. I put that there so that you would understand that there are relatively safe, which is L1, L through L3, and there are some considerations that we have to consider for all medications. That's the only reason they're there, okay? But one of the things I want you to notice about particularly this slide is, and again, I want to also just put a disclaimer that for some of you, this may feel like, oh, I know this already. But understand that LER, we have a wide range of learners, and not everyone has a healthcare background. So the drugs ending in IN, most drugs, these could be considered antibiotics, not all, but antibiotics are commonly prescribed. Sometimes they're prescribed during labor, sometimes they're prescribed afterward, and you will get lots of questions about, hey, is this safe? As a general rule, antibiotics is compatible with breastfeeding or providing human milk. Cipro is one of the medications that's been associated with GI problems. And so the biggest concerns with taking antibiotics is really the changes to the gut flora and development of antibiotic resistance. So again, if you're not familiar with the names of many drugs, it may help you to know that most antibiotics end in CIN as an ampicillin, and that's true for many, but not all antibiotics, okay? Antifungals. These drugs are used for fungus infections and sometimes thrush or Candida albicans, which is an oral infection. And they're used for other fungal infections as well. So one of the things to note about this medication is this class of medication is commonly prescribed for an infant that's been diagnosed with thrush. When an infant is diagnosed with thrush, or yeast in the mouth, oral yeast, the parent should also be treated simultaneously as the infection can pass back and forth. So just want to be clear on, again, the class of medication. There's the drug name, there's the common name, and again, just forget about the lactation category. This is just for your own personal knowledge. Analgesics are pain medications. So not sure how a question may be worded, but it might mention analgesics. So just know that that's the class of pain meds. Then we know that this is a common medication even after birthing. So this is a busy slide because, you know, when we think about pain medications, some pain medications are in combinations. So for example, you got acetaminophen and codeine, which is Tylenol 3. And when you look at the L category, you see that acetaminophen is an L1, but codeine is an L4. L4 is a big pause in the lactation world. And there's actually, the FDA has said to not prescribe Tylenol 3 anymore to anyone who's lactating. So looking at these combination medications, again, if you look at Norco, for instance, it's a combination of acetaminophen, which is Tylenol, and hydrocodone. However, hydrocodone is an L3. So I just want you to kind of see what some of the combinations could look like, as well as be aware of the safety components of analgesics. The other thing is sometimes analgesics can be abused and misused. These categories are specifically stating if you're using it as prescribed, okay? But going further, one note about aspirin is pretty much avoid this medication because if the infant has a viral, if the infant is susceptible to raised syndrome is what I'm trying to say. It's associated with the syndrome. Some of the concerns, if someone is taking, for instance, narcotics, because some of these are narcotics with pain medication, is the infant can be sleepy or it can cause poor feeding. All right. Anti-seizure medications, which is also anticonvulsants. Again, looking at this slide, you will see that Depakote, which is an L4, is one of those anticonvulsants to give pause to, but for the most part, you can take anti-seizure medications and still be able to offer your human milk to baby. So some of the infant concerns, same as with the analgesics, would be infant concerns for sleepiness or poor feeding or a baby that's irritable. Antidepressants, there's so much controversy over antidepressants and lactating. However, Hell lists the major antidepressants, the most common, not the major, I'm sorry, the most common as L2s, which is your Zoloft, Prozac, and Plaxil. Again, same thing. If you see a pattern of these medications, what you will notice is that some of the infant concerns involve sleepiness, poor feeding, low muscle tone, agitation. So either it's going to be that or GI upset is what I'm saying. Sometimes there could be withdrawal symptoms if the baby was exposed to antidepressants during the pregnancy. So just keep in mind, these are just general principles of these medication classes. Antihypertensives, it's not uncommon anymore for families to leave on some type of antihypertensive, which is blood pressure medication. So looking at this list, I just want to, you'll have this in your handout, but I do want you to go to the bottom where we're talking about hydrochlorothiazide and furosemide. Those are what we call diuretic medications. They really what they do is they get excess fluid out of the body. And because of that, notice I have an asterisk next to them. They have the potential to reduce milk supply. So this is in a common class of antihypertensives. So sometimes if they're prescribed this question or may say, I was prescribed a medication and now my milk supply, you start to dig a little deeper or may ask questions, and that's how you make it applicable to practice, right? Notice also infant monitoring is the same exact thing. Sleepiness, lethargic, pallor, poor feeding. So keep in mind that if you get questions about medications and things to look for in infants, they're generally about the same. All right, vaccines. Generally speaking, vaccines are safe while breast and chest feeding. However, yellow fever vaccine is not recommended whatsoever. The smallpox vaccine is another medication that's inadvisable for any lactating mothers or any bottle feeding mothers, actually. Any infant younger than 1 year of age, nursing or not. It's the personal contact, not the breastfeeding, that causes the risk. Therefore, there's no advantages exist to weaning if the medication is necessary. However, this vaccine is not really given routinely and is rarely indicated. All right, I added just a few more slides to this section. So we're going to switch from medications and vaccines to birth trauma and injuries. You know, birth trauma has the potential to impact breastfeeding and chest feeding. Some of the things you may in practice have seen or noticed already is that sometimes it requires careful positioning. Sometimes babies cry when they're in certain positions. Sometimes Based on the type of birth trauma, there can be a fractured clavicle. There can be a cephalohematoma that's directly related to maybe, say, a vacuum assisted delivery. And sometimes there can be trauma to facial nerves that may occur. Anytime there's the birth trauma, sometimes there are motor issues and like a fractured clavicle, but neurological issues or injuries. And so when you think about neurological injuries, you want to think about, again, the coordination of nerves. So there could be poor feeding, there could be slow feeding because of the speed of the motor movements. There could be abnormal swallowing and an increased risk for just poor feeding in general. So birth traumas have the potential to impact the breastfeeding and chest feeding relationship and experience. All right, inborn errors of metabolism. These are um, metabol conditions that occur that infants are generally born with through genetics, some type of genetics. So these infants are at risk for failure to thrive, as well as neurologic injury, what I just spoke about, acid-base imbalances, and other life-threatening conditions. There is one, galactosemia, where if an infant is diagnosed with galactosemia, usually a few days after birth is when you find out, human milk and breastfeeding is contraindicated. All the other inborn errors of metabolism, you may be able to partially or fully breastfeed with proper management and supplementation. And I've listed a few of the inborn errors of metabolism on this slide. So there's PKU, maple syrup, urine disease, milk urea cycle disorders, etc. So just be aware that galactosemia is the one that's truly contraindicated. All right, respiratory disorders. They also impact an infant's ability to effectively feed. You will notice, or in practice, you may have seen already, increased breathing effort, and that leaves less energy for feedings. One, I'm going to review two of the most common that is spoke about in the literature, and that's laryngomalacia, which means the epiglottis in the back of the throat collapses the airway. And sometimes you'll hear this inspiratory stridor. And what that means is when the infant is breathing in, you hear this sound like that. I don't know if that's the real sound, but it sounds something like that. And sometimes it sounds a little like, whoa, it's off-putting and can be scary for parents as well. With laryngomalacia, I'm speaking too fast, you can get these retractions that you see the infant is working to breathe. And when I say retractions, I mean indentations up here, above their sternal area. This condition peaks at about 6 months. It usually resolves itself between 18 to 24 months. It is associated with gastroesophageal reflux, as well as increased risk for abnormal swallowing. So, as it relates to feeding strategies, what are we talking about this for? There are some strategies, and that is head extension and prone positioning during feeding, and also short, frequent feeds to prevent failure to thrive. Remember, with increased breathing effort, there's less energy for feeding, so babies may not feed for long periods of time. Next, there's tracheomalacia, and that's the partial collapse of the trachea. And then there's sternal retractions heard, and they're heard as stridor. And so when I say sternal, what I'm talking about is the center of a baby's chest. When they breathe, it'll cave in. And you'll notice with tracheomalacia that there's a marked increase with the work of breathing. And so for all the previous slide, as I mentioned, laryngomalacia, the same thing applies. The feeding strategies, prone feeding is the same. This is usually outgrown in 1 to 2 years of life if the airway is anatomically correct. All right. Congenital heart defects. They can be on a continuum from of mild to severe. You can have cyanosis, which is bluish discoloration of the skin, rapid breathing, which may look like respiratory distress, but it's respiratory distress because of the cardiac impact, shortness of breath, low oxygen levels. Conditions that are cardiac may or may not require surgical intervention. It just depends on the severity of the cardiac the malformation. So cardiac disease is not a medical indication to just cease breastfeeding. Some of the strategies as far as feeding modifications could be small, frequent feedings or unilateral feedings, and again, upright or prone feeding positions to improve the coordination of swallowing and breathing. So that concludes the portion of some of the things you may see or may not see on the exam. If this was your first time seeing those things, please look them up, study them just a little bit more. But I tried to give you a little bit extra than what I usually give because when we think about patho and physiology, there's a lot to that. So this is a novice entry exam. So I'll let Angela take it away.
Thanks so much, Sekeita. So someone else just popped into the chat. What is unilateral? So that would be just one breast during a feeding. So shortened feedings and or shortened amount of time, as well as positional changes. And Sekeita did that great example of Strider, of the inspiration noise that is made with tracheo, as well as something similar with laryngomalacia. So indeed, those were correct, at least according to me. So, all right, so the next topic that we're going to talk about is breastfeeding beyond the first month. And we do have a couple of courses on this, such as our infant growth and development and breastfeeding the older nursling baby, as well as weaning. And, you know, the exam results show us that most test takers, most students will perform really well in that first 5-day time frame. But then sometimes when you're dealing with sometimes the older babies, that's where some folks can falter a bit. So when counseling clients with older nurslings, be mindful that the number of feedings and the time at the breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and again at 3 to 4 months. Developmental milestones may increase night waking in nursing. These little ones seem to be too busy exploring their world during the day to spend time at the breast. They may miss something. Therefore, they may wake more frequently at night to receive the caloric intake they intrinsically know they need. Latch and position technique are considerably more flexible after the first few months. Note in the picture here, the baby is further away from the breast than when a newborn, that picture of the baby on top. Unless the mother's uncomfortable, there's really no reason to suggest changing the position or the latch. And the other picture is there just to help people to become more familiar with seeing an older child at the breast. Now, breast and nipple pain are two challenges that some parents face while lactating. This is one portion of a 13-page algorithm developed by University of North Carolina for breast and nipple pain. It's a very valuable resource and a good review prior to the exam for how to identify many of the causes of breast and nipple pain. And yes, this slide is included in the handout. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin and heat, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be somewhere between 3 and 20%. Depending on the definition and the length of follow-up postpartum. Now, technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis and to abscess if treatment is not introduced properly. Symptoms include a fever of 38.5 degrees centigrade, which is 101 degrees Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area could be seen as red or hot or tender to the touch. And the red blotches or streaks or bruising of the breast tissue, which are more evident with lighter skin toned folks. Now, the treatment for it is almost always rest. Continue to feed and or pump on the affected side. Cold compresses to reduce edema. Creative nursing positions can be helpful. There's a new technique supported by Maya Bowman, IBCLC, which talks about moving the breast or breast gymnastics, which can be very helpful with clearing any sort of blockage which could be in the breast. Support compliance with antibiotics if prescribed, and use analgesic or anti-inflammatory for discomfort, fever, and swelling. Now you'll note here that the picture on the slide is intentionally chosen. This parent did have mastitis. You notice that this baby is a bit older, and it can be challenging to note that overt inflammation or redness in someone with a darker skin tone. Now, recurrent mastitis can be caused by delayed or inadequate treatment of the initial disease. Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding: A Guide to the Medical Profession, as a common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic people. In the case of recurrent mastitis, the diagnosis can be made with a milk culture and or an infant nasopharynx or oropharynx culture. Now, treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol on the mastitis spectrum. And many times people will ask whether or not that protocol, which was published just last year, will be available or will be questioned on the exam. And the answer is probably this year. Yes, it may be. So do become familiar with the new protocol. Also, another comment about the mastitis protocol is that the new one from the Academy of Breastfeeding Medicine is slightly different than the previous one. And so remember that in topics such as this, it's helpful to sort of like find that middle ground. For example, many lactation consultants will say, massage the breast in order to help with the abscess. But as the new mastitis protocol talks about, it's that aggressive massage and people who actually bruise themselves and can sometimes cause more harm. And so again, as with anything, some parents really do like that massage, but remind the parent to be gentle and not to cause pain, discomfort, or discolor the breast tissue when they are employing breast massage. Now, a small percentage of breast infections could develop into an abscess. Kinley reported that the incidence somewhere between about 5 to 10%, whereas Amir reported about 3% of women with mastitis in her sample developed an abscess. Now, one theory is that healthcare providers are more educated in the prevention of abscess. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. Now, the definition of an abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast, as you can see in this picture. And this picture, of course, is an obvious breast abscess. And there are occasions where an abscess can occur in the absence of any systemic symptoms. Usually the abscess rate increases when antibiotic treatment is delayed beyond 24 hours. So treatment options include, for small abscesses less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic, which is effective against any sort of penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote that drainage, and the incision heals from the inside out, usually within a week or two. And a parent can continue to nurse on one or both breasts, depending on the location, the associated pain, and the actual medication. So nursing through pregnancy. A pregnancy can occur while nursing. Explore the parent's feelings about continuing breastfeeding. Some women will note nipple and/or breast discomfort. Indeed, some report that this discomfort alerted them to the new pregnancy. Depending on the age and nursing relationship, some nurslings may be reluctant to wean. Now, mature milk will change back to colostrum around 4 to 5 months into the pregnancy, which may change the taste and the quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There's no need to wean a nursling child, or unless there is a true risk of preterm labor. There's limited data which shows the impact to the mother's nutritional status by continuing to nurse through the pregnancy. Therefore, it's important for the mother to be mindful of their diet. Now, some older babies and toddlers may stop nursing during the pregnancy, but then resume soon after the birth. Tandem nursing is the term used to describe breastfeeding of 2 or more children who were not born at the same time, or they are of different ages. It occurs when a parent nurses through a pregnancy, or if a previous child weaned during the pregnancy, they may be interested in resuming. It's important to explore the parent's feelings about tandem nursing. As one of the pioneers in the lactation field once said, Shelley Marmette, it takes the patience of Job to tandem nurse. If there's an issue with the infant's weight in the early days, ensure the newborn is given priority at the breast. Some mothers will dedicate one breast to the newborn and the other to the toddler, and then switch the next day. Note here that the older sibling has their arm around their new brother. Granted, it may be so everyone can fit on the parent's lap, but it also may be a sign of affection. Weaning. If a parent expresses a need to wean, it's important to explore their reasons. Now, some families believe that weaning may increase a child's independence or help a child sleep more at night, which may not be achieved through weaning. Gradual weaning usually works best for both the parent and the baby. It reduces the risk of severe pain and mastitis. In several texts on nursing a toddler, the first suggestion on weaning is don't offer the breast and don't refuse a child's request to nurse. Eliminate a feeding every 2 to 4 days, preferably not back-to-back feedings. Continue as both the parent and child accommodate to the new routine. The parent can hand express for comfort as needed. Change the daily routines for the child so that alternatives to nursing are offered and explored. Offer other foods and drinks just before those regular nursing sessions. And breastfeed when asked, but for shorter periods of time. Okay, so now I'm going to take a pause and see if there are any questions. Sekeita, is there anything here before I go into milk supply? Checking here real quick to see if there's anything. I don't see any questions, so I'm going to go ahead and continue. Sekeita, is that you?
That was me. I had come off mute. It looks like
We're doing
there's a
good, right?
question. Yeah.
I see it.
Okay.
How often to breastfeed when starting solids? It really is up to the parent and the child, and it also depends on when you're starting solids. It would be suggested that you wait those 6 months. I'm sorry, that you, that you wait until the child is 6 months old before starting solids. That's what the WHO and the American Academy of Pediatrics recommends. And so waiting for that 6 months, it really does depend upon the child. Some children will take to solids really well and will leave nursing behind rather quickly, and others will not. So it really does depend upon the parent and the child. So that's a really good question. Let's see.
Yeah,
Go ahead.
Angela, will you address the slides? What's in the slides? There's been a couple questions and concerns that not all of the slides are included in the handout.
So that's true. All of the slides are not included in the handout, and so we just included the ones that we felt were most important, and the ones that had the most impactful information on them. So we didn't include all of the slides. It's just a heck of a lot. Plus, you can watch this presentation as many times as you need to. There is no fee for it, and so if you need to watch this 10 times, please do watch it 10 times and take as many notes as you need to. And I see that Julie has made the comment as far as where you can find the handouts. And so indeed, you can click the handouts when you're, take a look at the notes or in the comment section that Julie has provided to everyone, or she's commented for everybody. And so indeed, you can find that handout by clicking on the name. If for any reason you have a hard time getting a hold of the handouts, please do email us at support@lactationtraining.com, and we're more than happy to provide them for you. I see someone here has asked, change color when breastfeeding while pregnant. Yes, the mature milk will change back to colostrum, and therefore the color will change as well. What age is it developmentally and appropriate to safely wean from middle of the night feedings for healthy full-term infant exclusively breastfed? So there is no age that is recommended when you can safely wean for night feedings. And really one of the reasons why is that some children, especially toddlers, will get a majority of their milk in the middle of the night. And so weaning at that time when during the day they may be developmentally appropriately distracted by all the comings and goings of the different, people in the household or the different things that actually happen in the house. So indeed, weaning at night is really something which is quite personal. Indeed, I do know people who say, oh, I really need to get some sleep and I really do need to wean the baby at night. Explore with them ways that they can actually get more rest when needed and when necessary. Also, the hormones of lactation are really interesting, and they actually protect that breastfeeding or lactating person from needing additional sleep. And so I read a book unrelated to lactation many years ago, which said that the only time in a human's life when you can actually survive with less sleep is when you're pregnant and nursing. And so indeed, some of the hormones of lactation are very protective. And so it is something which can be very helpful and very soothing to know that the parent, when they do get sleep, when a nursing parent does go to sleep with an older child, that actually they're able to function in a way which is safe when they are nursing. Okay, now I'm seeing all of these questions here about older babies. When starting solids, do you offer the breast first? Again, it depends on the child, and it depends on the schedule, it depends on the age. Let's see, and then another question, because there are some questions here, Sekeita, that we'll save for the end. I'll go ahead and flag them for now. Let's see, since oxytocin is blocked by progesterone, does that mean less milk is ejected during the feeding? No, it's just that the uterus is not going to pick up on those signals. There's uterine contractions whenever there's oxytocin. And so some are concerned that will cause, premature, that will cause premature birth, but the progesterone actually blocks it. And as far as the amount of milk which is ejected, a lot of children, older children who are actually verbal, will say that there is less milk, but they say that they're able to get what they need. And so again, this is hearsay, and there's no RCT that's going to help us with this. But indeed, I'm going by the experience of working with many parents of older nurslings and those who are verbal. So again, if that is something that is new to you, then you definitely want to check out the section on the older nursing child. And then finally, will a parent get engorged if she never stops breastfeeding? Will she just continue breastfeeding? Yes, milk will be produced as long as there is either a child directly nursing from the breast or they are expressing their milk. So indeed, I know some parents who will gradually wean when weaning finally does happen, and they don't necessarily get engorged because there's less milk. And also those who nurse for an extended period of time, we're talking, they will either nurse and or they're pregnant and they continue nursing through pregnancy. So I do know several people who have lactated for many years, if not decades. And so they still will have milk as long as there is a nursling who is there or there's some sort of milk expression which is happening. So all of these things are fascinating. And so thank you for the questions. Okay, I'm going to go ahead and move on to milk supply. And please do keep those questions coming. That's what makes this fun for all of us, and we all learn. So here's a picture of the neuroendocrine reflex arc, just to remind us of that physiological mechanism of lactation. Milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue, as I was just alluding to with those older nurslings. Now, this is a slide you may have seen in our anatomy and physiology course, as well as the relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes, such as retained placenta or lack of pituitary prolactin. Say that 3 times fast. Glandular causes may be surgical procedures such as reduction mammoplasty or possibly insufficient mammary tissue. Now, postglandular is going to be any cause for ineffective or infrequent milk removal. So iatrogenic causes of lactation failure are those which are impacted by policies and procedures in hospital or by healthcare providers, which have negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be included here. So as I mentioned, postglandular can be any cause for ineffective or infrequent milk removal. So the separation of a parent and a baby is one. Pacifier use is another. And as mentioned in the previous slide, perceived insufficient milk by staff or family, which leads to supplementation. Now, interventions which require supplementation in milk supply, which is not simultaneously supported with hand expression or pumping, could be one of those reasons. So you want to consider the supplementation scenario. Parents are told that they have to supplement their baby, and they may feel that breastfeeding has failed, and they're worried about resuming. Well-meaning healthcare providers may not encourage, or there may not be that warm handoff to the community lactation support providers on how to resume breastfeeding safely if those interventions are effective, right? If the parent starts supplementing and the baby starts to gain weight, so parents all of a sudden think, oh, breastfeeding failed, and therefore I need to continue to supplement. And so we want to make sure that there's that warm handoff to make sure that the parent is aware of when they need to start again. So think of a baby, for example, who's diagnosed with hyperbilirubinemia in those early days, and they start supplementation with breast milk substitutes. Or let's say there's a 2-week-old baby who isn't gaining effectively, they start supplementation, and then, the parent thinks, oh my goodness, well, in both of these cases, the parents may be too afraid to resume that exclusive breastfeeding or chest feeding or human milk feeding, and the healthcare providers, they may not have the time to create that care plan to help to return the baby to the breast. And so these are all examples of some of those postglandular reasons why the milk supply could be impacted. Also, keep in mind some cultural beliefs that could create a barrier to normal breastfeeding or chest feeding, such as colostrum not being enough for the baby, or in some cultures, the colostrum could be bad for the baby. So structural issues include surgical interruptions in the breast or chest area, biopsy, reduction or an augmentation of the parenchyma of the breast tissue, chest tissue. Now, a chest tube as a preterm baby or thoracotomy prior to mammary development, mammary hypoplasia or insufficient glandular tissue, and mammary asymmetry, including intra-mammary distance, which is the space between the two breasts. Now, chronic illness such as hyper or hypothyroidism, lupus, Parkinson's, diabetes, and hypertension. Acute illness or birth-related complications, including hemorrhage after birth, especially causing a large sudden drop in blood pressure and or requiring a blood transfusion. As a point of reference, 500 milliliters of blood loss is considered normal. Now, hemorrhage may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues include irregular menses, infertility, obesity-related issues, PCOS, weight loss surgery, specifically gastric bypass surgery, which can impact the amount of nutrient absorption. Other factors for delayed lactogenesis 2, which is greater than 72 hours, include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Nomson Rivers, which describes 3 factors for delayed lactogenesis: a higher BMI, increased maternal age, and larger infant birth weight. These are known correlates with carbohydrate intolerance and systemic inflammation. And finally, I think it's important to mention fat-phobic bias and staff who may be unaware of their bias. Therefore, they're not offering to help those folks who have the higher BMIs and or are larger. Other factors include hypertension, high levels of stress to the mother and fetus during birth, cesarean birth, especially when it's urgent, prolonged stage 2 of labor, which is greater than an hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery. The timing of the first breast stimulation following delivery, remember, it's important to try to intervene and do that breast stimulation within the first hour, definitely within the first 6 hours after delivery. Significant edema of the extremities as seen on this picture, and endocrine disturbances. So you can see there are complex interrelationships among the various factors that may affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiologic response due to the delayed or ineffective sucking, or a combination of factors, that has not yet been clearly identified. Early, frequent, and effective milk removal appears to be the most important factor in establishing normal lactation. And I would frankly argue that skin-to-skin and milk expression in that first hour or 2 after birth as key factors to counter the possible risk factors. Those of you who work in a hospital setting can understand how that may be impeded with any of the above diagnoses. Now, the infant's role in milk production. Any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course. Remember that late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy. Any tongue mobility restriction can impact not only the parental nipple discomfort, but also the ability to remove milk. Palatal issues obviously include partial or complete cleft of the hard or soft palate, but also includes a high bubble or channel palate, and airway issues, as Sekeita mentioned, such as laryngomalacia or tracheomalacia. And here I see this picture again, where we've got in the immediate postpartum time frame, infant hypotonia or hypertonia, birth trauma pain such as shoulder dystocia, or the use of forceps and vacuum. And that's actually what you see on this image, that red circle on the baby's head and those little darker spots. That was during a time when there were internal monitors which were used in the infant. And then you'll also notice that that is the swelling on the baby's head from several vacuum attempts in order to get the baby born, to be born vaginally. Cardiac or respiratory issues can also have an impact. Long-term impact include those infant facial anomalies of the tongue and the palate, and any sort of sensory integration issues that the infant may have. Now, there are a few solutions to get off to a good start with building a milk supply. During the hospital stay, you want frequent skin-to-skin contact. Honestly, you can't overdo that. Frequent colostrum or milk removal. Hand expression seems to work best. Now, a quick note, for mothers who are pumping for their premature infant or having trouble extracting an appropriate amount, the utilization of other senses can help with the milk ejection reflex. A study noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos as well, and smelling their t-shirt or blanket from the day before. Anticipatory guidance about normal newborn circadian rhythms can be a helpful solution. Visuals of the infant's stomach and the nominal nutrition requirements in the early days. Realistic expectations, alternative supplementation techniques if required, and important follow-up. Sekeita, are there other questions that we should answer at this point?
Yes, there's tons of questions. I've been busy trying to type
You and
and
Julie are answering like crazy, I see.
listen,
Okay.
I'm trying to keep up. I'm not Julie, but I'm trying. But as I was just typing, maybe you can answer this live. Is preterm delivery a risk for delayed lactogenesis too? Um,
Go ahead.
well, I was typing it. So, yes, preterm delivery is a common concern and risk for delayed lactogenesis too. And so I hope that answers the question live, and I can stop typing my answer. There you go.
And I think it's important that preterm delivery can be, but it's
Yeah.
important that early and frequent milk removal is key, as is a bunch of skin to skin. So helping that parent to advocate for themselves to get the milk expression going as soon as they possibly can, as well as being the advocate for the parent and teaching them to advocate for themselves for skin to skin. Those are excellent things. And they haven't quite teased out those pieces yet to know whether or not if that's the reason for the issue with delayed lactogenesis too.
Right.
Okay. And
Um,
someone has the question, the stages of lactogenesis and the new term, and someone is asking whether or not the new terms will be used on the exam. That's a good question.
yes.
I am unsure. I think it's important to know both areas,
Yeah.
both of those terms, the previous ones as well as the newer ones. If you're only aware of one, there's lactogenesis 1, 2, and 3, and 4, right? I think. I'd have
Yeah.
to check my books, but I
So
think
there
there's,
is a secretory differentiation, which is lactogenesis 1, and then there's secretory activation, which is lactogenesis 2. Um,
brilliant.
and so I hope that that clears that up, but um, I don't know what terms they'll be using on the exam. I often see different questions phrased in a way where it could be both, or that you're supposed to figure out which one is which. So,
True.
it's important to know both.
I agree. And then there's also galactopoiesis, right? Which is that
Yes,
homeostasis and that regulation of milk production until weaning. So,
right.
okay, good. All right. I'm going to go and Julie asked, or there was a question as well about the Dalton's issue. And so there we go. So and she answered it for everyone. So if you take a look in the chat, actually, I should probably say that. I think that one may be important. What do you think, Sekeita? Someone,
I actually answered that one. The Daltons.
yes. How
Yes,
many
I
Daltons
answered
would
that.
be considered safe for a medication not to diffuse in breast milk? So,
Right.
and the short answer, medications with molecular weights less than 300 are considered smaller and will tend to penetrate into milk in high concentrations than those with higher molecular weights. So that's the short answer to that question. Okay,
And
great.
yeah, there's
Yeah,
also, if you keep reading, there's about 600 Daltons was, I believe, the specific answer to that question. But I put um, the whole verbiage from hell so that there's no confusion. The other thing I want to say about when we talk about ranges, keep in mind there's that different textbook may have different ranges and different information. So keep that in mind as well. But I did put the most recent from the website actually. And so that is the most current, I would say.
great, excellent, yes. And for someone who's looking for the different terms of lactogenesis, you can go take a look in one of our bookstores. You can take a look in the bookstore, and I would say go to the lactation text that you're using. I think that it is important to have at least one lactation text. And we have a webinar the 90 days prior to the exam and creating a study plan that you can actually find on our YouTube page. And so go take a look at that one if you're still in need of a textbook. And then someone asks the question, which always makes me smile, why is there a difference in supply with the right breast and the left breast? Just because you have two does not mean they are equal. Therefore, many parents will report that one breast will produce more than the other. It could be glandular tissue. It could also be that a baby prefers one side over the other. It could be that a parent and their handedness, they prefer to put the baby on one breast versus the other. And so indeed, that is a very good question. And indeed, you have two, so that's why they're not necessarily equal. So, okay, great questions. Thanks, everybody. This is good. Now, let's just do a quick overview on research, and then I think Sekeita's up after this. So now, research, variables in experimental study. The dependent variable is what the independent variable is acted upon. What the independent variable acted upon. In a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable, and the type of pump is the independent variable. Now consider what we know about effective pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent pumped. That might lower the amount that they're able to extract. Or time of day could be a confounding variable. And to the person who asked the question about right breast and left breast, that could be a confounding variable as well, but controlling for that would be quite challenging. Now, I just want to review some frequently used terms. Now, the standard deviation is a measure of how spread out the numbers are. 68% of the results will fall into the first standard deviation, the green. 95% will fall into the first and second standard deviation. 99.7% will fall into the first, second, and third standard deviation. So there's only going to be a few in that fourth standard deviation. Now, statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05, which is most medical research. Bias. There are different types of bias, and it can influence research. For example, that piece of research which looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute. Now, you note that the university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from that pump company could be biased in their study design and or the interpretation of the results. So it's always important to take a look at the bias and to find out where the funding has come from for any specific study. And I always find it interesting when I see studies which do not show any benefits of breast milk or breastfeeding, and it's always interesting how sometimes they're funded by certain pharmaceutical companies. Pardon me. Informed consent. Subjects need to be informed about their rights, equipment, and or medications used, the procedures, the confidentiality, and withdraw from the study at any time, and how they do that, and any rewards for participation. Okay, great. So that's a quick one on research. And now we're going to go into the actual questions. We're going to ask you some questions this time. And so we're going to go into the actual questions that we have for you, and then you can answer those questions, and we can you can sort of test your skills to see how well you do compared to these questions. Now, these questions, we're talking about overall concepts here. And so remember that piece of it, that we're talking about overall concepts and not necessarily what's done in your facility or your country. For example, you may see a reference to varicella zoster in one of the subsequent questions. Now, during the previous exam prep, we reviewed the recommendations for varicella zoster, and we'd found 3 different answers. When that occurs, please look to the international resource as you're doing your studying. If there isn't an international resource or a clear-cut answer, understand the why. One may be able to assume that there will not be a question about it on the IBLCE exam, but if there is, understand the why for the rationale and understand understand the why, and then hopefully that will help you to answer a question which you may have seen some conflicting information for it on the exam. Okay, so hopefully Jill is ready for me to pull up these questions. Now what I'm going to do is I'm going to have the slide up for a few seconds, and then Jill is going to pop the poll question into this GoToWebinar platform. And the poll doesn't allow for the picture or slide to show. So I just want to explain the process real quick. Okay, first question is, a physical breast presentation which may contribute to low milk supply is a significant inframammary fold, a breast cup size less than B, significant intramammary distance, or hypoplasia of the superior breast tissue. Okay, Jill, go ahead. Thank you very much. We're collecting the responses. We'll leave it open for about 30 seconds. So go ahead and vote to your heart's content. You can only vote one time. Oh, good. I don't think we fooled many of you. Okay, go ahead and close it, Jill. So yes, the correct answer is significant distance between the breasts, aka intramammary distance, may be associated with hypoplasia. Cup size does not necessarily indicate glandular tissue, and hypoplasia of the upper breast tissue is also not an indication with insufficient glandular tissue. It's hypoplasia of the lower medial and lateral quadrants do. So the correct answer is C. Okay, going on to the next one. A post-glandular reason for insufficient milk production is A, early introduction of hand expression, B, pacifier use, C, retained placenta, or D, previous breast biopsy with a periareolar incision. Okay, Jill, thank you very much. Post-glandular reason for insufficient milk production. Well, we're not fooling any of you on one of the responses, so good. None of you are going for that one. So answers are a little all over the board here. Pardon me, I'm going to take another sip of tea. Okay, good, Jill. Thanks. So the correct answer is B, pacifier use. Remember, it is after the birth. And so pacifier use is the correct answer. The previous breast biopsy with the periareolar incision probably didn't occur, probably occurred prior to the pregnancy, probably. And the retained placenta is something which is a preglandular. Is that what I said, Sekeita? I think I said a preglandular or glandular reason, retained placenta. It can't be glandular, it must be preglandular. Okay. Yes, I do talk to myself on the regular basis. While reviewing your postpartum patient's chart, you see they receive Pitocin, synthetic oxytocin, and Methergin after a vaginal delivery. You know this patient most likely experienced normal blood loss, experienced excessive blood loss, gave birth to multiples, will not be able to breastfeed. Okay, Jill, go ahead. So did this person have a normal blood loss, excessive blood loss, gave birth to multiples, or will not be able to breastfeed? Oh, there are no sophisticated distractors with this one. I think everybody here is on point with knowing the answer to this one, so great. Another couple of seconds. Okay, good. Thanks, Jill. So yes, the correct answer is B. The first-line medication used in the management of excessive blood loss during the third and fourth stage of labor is Pitocin. If bleeding does not decrease, a second medication is indicated. So providers may choose among several second-line medications, including Methergin. A is not correct because the management of normal blood loss does not require 2 medications. And C is not correct because twins do not require 2 medications. D is incorrect because excessive blood loss does not necessarily mean breastfeeding will be unsuccessful. Okay, great. So here we have Lilo, lactation consultant, did a study in her hospital. Families were randomly placed into 2 groups. One group received an intervention and the other group received the standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, go. So randomized into 2 groups. What sort of research is this? The intervention or standard postpartum care? And again, another few seconds, we'll leave it open. Please vote, even if you're not sure. It's good practice. Okay, great. Go ahead and close it. So yes, the correct answer is A, quantitative. So quantitative research, here's a quick reminder. Qualitative research explores real-world context based on perceptions. It considers multiple perspectives, no attempt at causality, and use of interviews and observation. That's usually the clues that it's qualitative. Quantitative research is experimental research to discover causal or correlational relationships between the variables, and it's based on data collection and analysis. Okay, great. Now, Lilo is a busy person, and they did a study where they surveyed patients about their satisfaction with breastfeeding and what type of problems they encountered. What type of research is this? Again, quantitative, qualitative, historical, or epidemiological? Okay, go. And you see, I think because there's a few things here that may change your mind about which one it is. Another couple of seconds. Thanks for voting. It's great for you as well as for us. Okay, Jill, that's good. So yes, the correct answer is qualitative. So again, same description here, but qualitative explores real-world context based on perceptions. And the study that they're doing is on satisfaction with breastfeeding. So, okay, good. Next question. Iron levels are low in breast milk. What recommendation should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. Breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of diet in the amount of iron in the parent's diet to increase the amount of iron in their breast milk. Okay, so which one is the correct answer? I intentionally chose this question to give. And the reason why is because there are several people who are not really sure about this. And so indeed, the results are showing that some of you are picking those sophisticated distractors. And people are now all of a sudden changing their answers. I know. I'm going to give you a couple of extra seconds to think about it. Okay, great, Jill. Go ahead and close it. So the correct answer is C. Breastfeed and supplement at 6 months with iron fortified foods. Now, additional iron intake by the parent will not increase the iron levels in breast milk, even if the mother is anemic. Iron supplements taken by the mom may produce constipation in the baby. Anemia in the nursing mother has been associated with poor milk supply. So the reason I chose this question is because I do know that there is an exam prep out there which says to increase the amount of iron in the parent's diet. Unfortunately, I wish it were that easy, but the body is amazing. The human body is absolutely amazing. And so the type of milk which is produced is actually relatively consistent as far as some of the macronutrients and the micronutrients which are in the milk. So yes, some things can be altered, but iron is one of those things which cannot be altered by even taking high doses of iron. So there we go. And indeed, we don't need to start giving iron fortified foods or supplementing the baby until the baby is about 6 months, because that is when the iron levels decrease. Okay, now we have vitamin D, a vitamin D question here. Vitamin D levels are low in breast milk. What are the current recommendations? A, supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half an hour outdoor daily, the baby. D, baby should be supplemented with 400 IUs of vitamin D a day. Okay, go. And this is something which is good. For people to chime in on. Okay, let's go ahead and close it. Most of you got this one right. Yes, babies should be supplemented with 400 IUs of vitamin D a day. So indeed, it is something that needs to continue even after solids have started. So, and spending it a half an hour outdoor every day, while indeed that can be helpful, we also don't want babies to be burned. I do know parents who've taken their babies out hoping to get more vitamin D, and the baby, especially those that have a lighter skin tone, they could be damaged by the sun. And so, as well as what latitude, where does that family live, or where does the family live in the world, and what is the pigmentation of the baby's skin already? So there's too many variables there to be able to suggest spending a half an hour outdoors every day. Okay, so here we've got this baby, and how old is this baby? So I'm going to give you a few hints here. So this baby has a social smile, which is important. The baby is able to lift their head by about 45 degrees. The baby seems to be able to hold up their head for a few seconds. And visually, this baby is searching to look for a familiar face, or maybe there was a sound that was made. Now, how old is this baby? Is this baby 2 weeks old, 4 months old, 2 months old, or 8 months old? How old is this baby? 2 weeks, 4 months, 2 months, or 8 months? So this one has a really sophisticated distractor. This one's a little tough. I'm not gonna, but the reason I mention all the different things you want to look for is because, and I know you can't see the picture right now, it's because these are the sorts of questions which may be on the IBLCE exam, on the IBCLC exam. Okay, Jill, go ahead and close. So indeed, the answer is 4 months old. Now, most of you, and a strong majority of you, said 2 months old. And I can understand, oh wait, hold on, the baby is 2 months old. Even I got it. So here's the thing, this baby is only 2 months old. The baby can't hold themselves up for very long. Also see how the baby is using the entire part of their forearm in order to stabilize themselves. The fists are closed in order to stabilize themselves in order to lift their head up. So indeed, the answer is 2 months old, but the baby can only hold up their head for just a few seconds. A 2-month-old can do this. They hold up their head for a few seconds and boom, it just pops right back down on the on the table. So indeed. And I know this baby is 2 months old because the parent sent me the picture. So, okay, next question. Which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? Is it A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, D, cytomegalovirus? Okay, which of the following viruses is most likely to be transmitted to the infant through breast milk from the infected parent? And this is one which is a little tougher. And I can see by your results that you all are struggling a wee bit. Go ahead and answer. Got another 10 seconds. Okay, great. So the correct answer is D, cytomegalovirus. And the transmission of CMV from parent to infant occurs about 60 to 70% of breastfeeding dyads, where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV-positive breast milk. Herpes simplex virus, HSV, and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus causes chickenpox in zoster. Infected parents should be encouraged to breastfeed. The infant, however, should be protected from direct contact with skin lesions. So if there are skin lesions on the breast itself, on the chest, where the infant may touch, it's important to cover those. And if they're actually on the nipple tissue itself, then indeed, the baby would not be able to directly feed or receive the breast milk of that parent. Okay, 4 more questions. So, Tyler's diet is vegan. What would you suggest to ensure adequate nutrition for Tyler and baby? Protein from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, or B12 from fortified foods or supplements. Okay, go. So Tyler's a vegan. What is the thing that Tyler is lacking being a vegan, potentially? Is it protein? Is it minerals? Is it folate? Or is it B12? Another couple of seconds here. Okay, great, Jill. Go ahead and close it. So yes, the correct answer is D, B12 from fortified foods and supplements. So vegan diets include no animal products. To avoid a B12 deficiency, vegan nursing parents and those who consume very little animal protein need to take steps to make sure they receive vitamin B12, either from foods enriched with B12 or by taking supplements. So indeed, a vegan also may not receive protein, but usually it's the B12 deficiency, which is more of a concern as opposed to the protein. Okay, next one. A primary reason for providing human milk to premature infants is, primary reason, improved bonding between breastfeeding, chest feeding parent and baby, assure continued breastfeeding, chest feeding after discharge, significantly decrease the risk of necrotizing enterocolitis, or D, improve neurological outcomes. Okay, so what is the primary reason for providing human milk to premature infants? Improve bonding, assured continued breastfeeding or chest feeding after discharge, reduce necrotizing enterocolitis, or improve neurological outcomes. Okay, good. People are feeling confident with this one, which is great. Another couple of seconds. And yes, go ahead and close it, please, to prevent necrotizing enterocolitis. So that is something which is quite deadly in the NICU and amongst premature infants. So while the other ones are also important, preventing NEC is number 1. Okay, next question. A potential risk of skin-to-skin care in newborn infants includes A, respiratory instability, B, sudden unexpected postnatal collapse, C, hypothermia, D, sudden unexpected infant death. Okay, next, go ahead. Was it SUPC, SUID, hypothermia, respiratory instability? I did say those out of order. I apologize if I confused folks. Another few seconds. Potential risk of skin-to-skin care. Okay, go ahead and close it, Jill. So the answer is actually B, sudden unexpected postnatal collapse. So hypothermia is a concern, but it is not a risk. You know, it's important just to cover the baby, but SUPC is something which has been in the literature, I want to say, for at least the past 10, if not 15 years. And so it's important to know what the research is around SUPC. There are several journal articles which are available in order to prevent SUPC. And so safe skin to skin is something which is important. And so indeed, you know, skin to skin actually usually does, especially if the baby is covered, it does not cause hypothermia because the parent's chest keeps the babies warm, and it's not respiratory instability. Babies usually will stabilize respiratorily better when they're skin to skin with the parent. So, okay. Another picture, so we'll keep this up for another second. This hand technique, so focus on the hand technique, is useful for all infants except premature infants, Down syndrome infants, neurological impairment, infants with type 3 ankyloglossia. Ankyloglossia. Okay, go, Jill. So that hand position is useful for all infants except, so which group is it not helpful for? Okay, another few seconds here. It's helpful for all infants except. Okay, Jill, go ahead. So the correct answer is infants with type 3 ankyloglossia. And the reason why is because, now granted, hopefully you won't see many negative STEM questions on the exam. That except thing can throw people off. But this is known as the Danner hand position, and the answer hand position, as well as it's a straddle hold. You notice the baby is prone, is sitting upright. And so indeed, this position is helpful for babies who are premature, who may have a bit of hypotonia, especially in the jaw region. Babies with Down syndrome, who also may have hypotonia in the facial region, and babies with neurologic impairment. So all of these can be, this position can be helpful to help the infant to keep the oral pressure in the mouth, and can help the baby to nurse more effectively. Okay, so now here we've got the World Health Organization guidelines for the preparing of powdered infant formula. What do they recommend? A, boil the bottles and teats for 20 minutes, a rolling boil. B, boil the water used for mixing for 20 minutes, a rolling boil. C, mix the measured amount of powdered formula and hot water, and the hot water needs to be between 70 degrees centigrade and 158 degrees Fahrenheit. Or D, store prepared bottles in refrigeration for up to 72 hours. Okay, go. So when you're thinking of the WHO guidelines for the preparation of powdered infant formula, which one of these things is recommended? Boil bottles and teats for 20 minutes, boil the water used for mixing the powder for 20 minutes, mix the measured amount of powdered formula and hot water, or store prepared bottles in refrigeration for up to 72 hours. Give you another few seconds. Some of you are hesitant. Go ahead, go ahead and vote. Pick one. Okay, great. Go ahead, Jill. Okay, the correct answer is C. Mix the measured amount of powdered formula and hot water, and the hot water needs to be between 70 degrees centigrade and 158 degrees Fahrenheit. And that is right when the water comes to a boil, it is at that temperature. So you do not, and so yes, it does say to boil the bottles and teats, to clean them and to boil the bottles and teats, but not for 20 minutes. And it does say to boil the water used for mixing, right? Because that's B and C are similar, but it's not for 20 minutes. It just till it gets hot, and then boop, you can take off, or a tea kettle, an electric tea kettle will work beautifully with this. That as soon as it hits boiling, it shuts off. And so that's usually how I suggest that parents can mix commercial milk formula, the powdered. And then store prepared bottles in refrigeration for up to 72 hours is incorrect. It's only 24 hours. And so there we go. Those are all the answers to the questions. I know that some of you will say, how close is this to the IBLCE exam? I don't even have to look at the questions box. I know some of you will say that. Hopefully this didn't stress you out, but it gave you just an opportunity, just a little bit of an opportunity to sort of test yourself and say, where am I with this? Some of the questions may be worded differently. You may not have cared for some of the, questions, necessarily, but indeed, it's just an opportunity for you to say, okay, I really didn't know that answer to that question. I would say that powdered infant formula question was probably the one where y'all were really all over the place. So do take a look at the WHO guidelines for the preparation of powdered infant formula and be familiar with it. And then that way, hopefully it'll help you when you actually, if those questions are on the exam. So thank you for taking the little 14 question exam. I will take a pause here and turn it over to Sekeita, and I'll answer a few of the questions which are in the chat. Sekeita, ready?
Thank you, Angela. Yes, I am ready. Before I move into survival guide, I just want to thank you all for being patient with us. This was advertised as an hour, I believe, and we are now 32 minutes over. However, I'll go into the exam survival guide with a little bit more finesse and hoping that the next information is important. And so just give me just a few minutes to kind of go through. But I know we just went over a lot of information. Please keep in mind, for those of you that are in the United States, this exam is an international exam. And so hopefully you come away with this with knowing what opportunities for growth you have, as some of you may have 30 days, some of you may have 25 days, but hopefully this was helpful to you to kick in gear and so that you can be successful. So take a deep breath. I know that was a lot of information, and it was a lot, but there's still a lot more. And so I'm hoping this will encourage you to get your study guide developed and so that you can be successful. So next slide, please. All right. So while you just give yourselves a hand, period. You've made it to this point. Preparing for this exam has required a lot of dedication, endurance, and passion. And so what I'm hoping is that when exam day comes, that you reflect on that passion, dedication, and endurance and go in there with confidence that you're ready. So the last few days, stay connected means staying connected means studying. Celebrate your dedication. So do something every single day right after your study session and be proud and just trust that, you know what, if you've attended this session, you're in the right spot. Also continue to do questions because that's only going to help you further. And so fuel your passion so that you are successful. All right. Remember to breathe deeply. I don't know if you all heard this, but I did hear it myself breathe after. I'm kind of in this with you all as you were answering the questions. I'm just like, okay, this is the answer. Please get it. So breathe deeply. You will come across questions on the exam that's going to give you a pause. what you need to do is just take a deep breath, get that oxygen flow into your brain, and then, okay, answer the question. But remember, don't breath hold. A lot of us do that. And so this is just a friendly reminder. Breathe. So before exam day, some of the things you need to be aware of, you need to be aware of your confirmation number. You need to know what to expect. Now, again, I said this is an international exam. Some folks will be taking it inside of a testing center. Some folks will still be doing it remotely. In some areas, mask may still be required. And so make sure you know for your area, your regional area, your local area, or if you're taking it, make sure you know about the 3 security measures, the 3 security checks. Make sure you know about your breaks and make sure that you have a stable internet connection wherever you'll be sitting for the test if you're going to be taking it um, remotely. Along with particularly for remote folks, there are recommendations, there are computer system requirements. If you have not had a chance to look at the requirements that are required, they're really specific. So you want to make sure you have a screen resolution, that fits the size of 1024 by 768. You want to make sure the operating system that you have is correct. You want to make sure that you're using the Google Chrome web browser, your webcam resolution, and you do have to have a webcam. You have working speakers and a microphone. And also you want to know what to do if you have technical difficulties. I neglected, I am going to pop in the chat a checklist because there is a checklist um, that you can go to just to make sure. I hope that's the entire checklist. There you go. Just to make sure that you are prepared if you are sitting for the exam remotely. All right. Again, I said that some masks will be required. Make sure you know wherever you're sitting for the exam at, if you're going into a building, that you know if there are masks that are required or not. All right. Now, this is the part where you get to figure out what is your temperature now right now. And when I say that, what is your exam temperature? Think about what has worked for you in the past and then think about, okay, that did work for me. This didn't work for me. In all honesty, this is not the time to kind of switch up and do something different if you've been successful in one type of way, or maybe you're just not a great test taker. Then think about other ways of learning, other ways of doing, and other ways of being. I like to talk about different types of learning modes. Some people are visual learners, where sometimes doing concept maps might help you put the pieces together, particularly as it relates to the next step in practice. Some people are just linear, where you just take notes and that's good enough. Make sure you do what has worked for you in the past. And if you've not been successful in taking tests, sit with someone to determine what's the true method that can help you be successful this time. So this quote I want to leave you with: many students cannot pass their exam because they fail to sacrifice the minimum capital of time and, yes, sometimes money. So this is a quote: the capital of time is priceless. Use the time that you have left to prepare. So before exam day, please know you have to be alone. There can be no pets. There couldn't be anyone who opened the door just to check on you. None of that. There have been folks that have been disqualified, and that is heartbreaking. So you cannot be interrupted. You need to be in an area where the internet is strong as possible and there is good lighting. And this is if you're taking it remotely. Ask everyone to stay off the internet. You might consider hardwiring into your Ethernet system or into your Wi-Fi system. Ensure that you have the quiet time, the necessary quiet time, the 4 hours alone wherever you are. Before exam day, some helpful hints would be just write yourself affirmations. You can do it. Place it on your bathroom mirror, refrigerator, wherever you spend the most time in your home or wherever you're going to be. If it's work the day before, place affirmations around. Find a good podcast. Try to kind of decrease the stress level. Test taking can be anxiety producing. A little bit of anxiety is normal, but you do want to bring yourself down um, and do things that inspire you and energize you in that way. All right, night before the exam, find your inner calm. It's so important to get some sleep. Get some sleep and true sleep. Sometimes we ruminate and we think about those things. So if that means doing deep breathing exercises before, but find some way to calm yourself so that you are prepared and ready the next day. All right, it's the day now. Please don't try to eat something exotic. Like you might treat yourself afterward, but make sure that you eat something that your body is used to, comfortable clothing, trust your preparation. Most of you will be ready. I'm sure of it. I'm almost the way you answered those questions. So just you don't want to get sick on something that you eat new, but then you can treat yourself afterward. There are a total of 175 questions. There's two parts, multiple choice, and images. The exam is 4 hours duration and there is an allotted 30-minute extra time if the exam is not in your primary language. However, you have to have permission for that extra time. Each question has only one correct answer. There is no penalty for answering a wrong. So the best thing to do is if your mind goes blank, answer the question anyway to the best of your ability, flag it, and go back if you have time later. Test taking exam or exam strategies. Read each question slowly. Angela did a question, the last question and the end was accept. Remember, you have to read all the words. We particularly have gotten into social media now and texting age where OMW means on my way, all of that. So we're used to this fast pace. Read slowly, take your time, read every single word in that question, what it's asking you. Eliminate the obviously wrong answers. Watch out for the stem, the negative stem. And again, remember, this is an international exam. Work at a comfortable pace. Mark any questions you'd like to review. There's going to be a place where you can mark that. Make your best choice and move forward. And I think I jumped ahead and I said review if time allows already. So we can keep it moving. I'm trying to get you all out of here, but I'm trying to give you everything. First impressions. Remember, your first answer is usually correct. You want to don't second guess yourself. The only time to second guess yourself is if you know you got it wrong. Then okay, change it, right? But I've done this where I've changed my answer only to find out that I had the answer correct to begin with. Don't read more into the situation. The question is asking you exactly what it's asking you. Now, some questions are poorly written. There's nothing you can do about that, right? But just read the question and answer the question based on the information that's given to you. Try not to do the, well, what if this or what if that? Try to answer what based on what's given. Again, there are immediate termination or dismissal that can occur during your exam, and this is some of the criteria. You cannot leave the exam workspace at all. The only time that's permitted for you to leave is a break in between part 1 and part 2 of the exam, and you cannot assume that the proctor, like, you have to talk with your proctor if it's remotely and you have to ask, is it okay for me to go? Candidates must alert the proctor before moving away from the web camera during the break and after finalizing the exam. Two very important things. Leaving the view of the web camera without acknowledgement from the proctor, including during your scheduled break, will result in immediate dismissal from your exam. I've already talked about no third party or person can enter the room. Turning off lights or computer audio, or moving from an original testing location, or speaking to or receiving aid from any other people is strictly prohibited. So you're at the end of the exam. Sometimes you will get done sooner and you're like, I don't know, should I submit it? These are some of the ways. Just submit it. Just keep in mind that you're done. And everything always seems impossible until it's completely done. So some folks will walk out there like, yep, I blew that exam up. It's a wash. You know, some people will go out and like, I'm confident I won. Some people are just going to be done and just be done. And some people will be done and say, how did I do? Relax, treat yourself, and wait for those um, the exam results. The exam results usually don't come out until mid-December. And I'm saying usually because that has been the pattern. It could be different this year, don't know, but usually it's mid-December. So what I would love for you to do is just keep your passion going. That is the time while you're waiting is to just continue to grow, continue to get knowledge, continue to network, try to figure out what your next steps are. Try not to obsessively check the website or social media. Remind yourself you did the best and stay connected to your professional community. Remember your why always. So, one of your affirmations could be your why. Write a letter about your why and stick it somewhere and constantly resort to that. I wish you so much success. Angela, I welcome you back into, I know there was lots of questions. I tried to do this session really fast because I know we were over time, but I hope I did due diligence to it.
As always, of course, Sekeita, you did. Okay, good. So now we're going to, I'm actually going to stop sharing my screen. So now, even though those babies are super cute, but anyway, let's see. There was someone who asked a question about the preglandular, postglandular, and glandular reasons for lactation insufficiency. So just to remind you, and I'm actually reading from Morton's article, a preglandular cause for low or no milk production is directly related to hormonal issues, such as retained placenta or postpartum thyroiditis. So remember, it's hormone. Preglandular is hormone. Postglandular are things that happen after the baby is born, which get breastfeeding off to a bad start, like a baby who can't transfer milk appropriately, or poor breastfeeding management, scheduled feeds, extended separation of the parent. Glandular causes include previous breast surgery, hypoplasia, IGT, which is insufficient glandular tissue. Often glandular lactation failure is accompanied by one or more preglandular and postglandular factors. So hopefully that was helpful.
Yeah.
Yeah,
Angela, I just want to make a link to, because you
please.
said retained placenta. I think some people are thinking about it as retained placentas after birth, right? That post, right? They're not
Right.
linking the placenta as actually being a hormone. So the issue becomes the
Yes.
hormone that's attached to that retained placenta is what? Progesterone. So that is what makes it, um, a
The issue.
preglandular. Yeah, yeah.
Got it. Okay, good. I'm going to take a pause here and answer one of these questions, which is how many people pass the first time around? The answer is 75% of you, if not 80% of you, are going to pass on the first exam, on the first try. So hopefully that's just a little bit reassuring that most people, a strong majority of people, do pass the exam. So, oh yeah, go ahead.
Most people that are prepared for the exam pass it.
Yes,
Um,
there are the
I've, I've
rare people who don't,
I,
and
have tutored a few folks and I can tell if you're ready. And you know what? No, oh, there's a lot. And particularly when it's like 5 days before the exam. That's what I mean. I'm not talking about 30 days. I'm talking about 5 days. And so that's why I really made the comment of you being in this space is so important.
Yeah, yeah. Okay, good. Let's see. Someone asking why not use the standard or dancer hand position with type 3 ankylosing. This hand position is to help babies who are unable to obtain, sorry, unable to obtain a suction and an appropriate latch. And so while a type 3 tongue tie may cause an issue, chances are it's not going to affect the mobility of the jaw. It may affect the ability and the mobility of the tongue, but not the jaw. And so that's the reason why. Plus, understand that I put in that type 3 ankylosing because while lactation professionals may type them and give it a number and things like this, chances are, that may not be on the exam. The whole issue of tethered oral tissues is pretty controversial in our field. And so please don't assume that everything is due to a tongue tie, because chances are it isn't. Tongue tie is only a little bitty piece of what we need to know. So be mindful of that. Okay, let's see. What other questions? Oh, someone had a question. I'm going to look up the SUPC question, Sekeita.
Okay. I just want to add to that too about ankylosing because, the IBCLC, everything is scope of practice, right? And when we're getting into typing, the exam is not designed for us to be diagnosing, even if you are someone who can diagnose. And so sometimes that will throw folks off, when you get certain answers like that. So just keep in mind the scope of practice of an IBCLC. That also can help you on some of the questions.
Excellent, thank you. So on SUPC, someone said, well, why is skin to skin a risk factor? And that's actually from the research. The research is from 2014. It's Ludington, Ho, and Morgan, who've done a lot of work. Also Davanzo, Paul, and I know there's one other researcher who's not in this book, but whose name is escaping me at the moment, who did quite, Herlinius, I think it is, Herlinuis, and I apologize if I've just mispronounced the name. But actually, it's considered the skin to skin piece is if the parent is in a reclining position. So it's important for the parent to be in a reclining position, not flat. And so it's the flat skin to skin that is more of a risk factor than someone who is in a reclining or a semi-reclined position. And so there are certain components of safe positioning should be explained and demonstrated to the mother and family, including the parent's position, the infant's back is covered and the hair is dry, the infant is well flexed on the provider's chest, infant's shoulders are flat against the provider's chest, infant's chest to chest with the provider, not over a breast, infant's head is turned to one side, infant's face can be seen, infant's nose and mouth are visible and uncovered, infant's neck is straight, not bent. So indeed, there is an infant scoring system, the respiratory activity, perfusion, position, and tone, or RAPT infant scoring system that is performed every 5 minutes for the first 2 hours following delivery. And so it has to do with safe skin to skin and appropriate positioning. Anything
Yeah,
else I'm missing here?
I do. I want to just add that in some of the literature, it also speaks about distraction sometimes.
Yes,
And,
yes.
keep in mind that babies, when they're initially birthed, they're transitioning to extrauterine life. Now, the way we used to do things, and former labor and delivery nurse here, is we used to take the babies and put them on the warmer or take them to the nursery 25 years ago. And
Still
sometimes people
today.
wouldn't see their babies for years. And yeah, in some nurseries still, some hospitals still, right?
Yeah.
But the as we've gone and moved to this family-centered approach and to the biological norm of carry mammals, which we are, we put in babies. We have cell phones that are distractions sometimes, and we forget the critical moment of this baby is still just transitioning to extrauterine life, and there are things we have to watch for to make sure that that transition happens correctly. So the RAP tool is a tool for those who work and assess babies right after, while they're in skin to skin, to actually keep the providers to keep their attention as well, but also to
Mhm.
keep parents' attention so that the attention and the energy is focused on how well this baby is doing, whether it's skin to skin or not. And skin to skin is one of those things where we have to still be conscious and vigilant because that transition, it still can, there can be troubles during it. So,
Absolutely.
yeah.
Yes, that's true. Okay, I'm actually looking up the answer to a question, and I'm not sure if I can answer it. What are the caloric needs of preterm and full-term neonates?
Yeah.
Did you look
So
that one up yet?
that type of I'm not gonna look that question up simply from the standpoint that the pediatricians, the neonatologists, I should say, so not even the pediatricians, they determine caloric needs. A lot of it is based on, too, how well the baby is doing, how stable the baby is doing. What are the caloric needs of a baby who's born at 25 weeks gestation versus a baby that's born at 35 weeks gestation? They're
Thank
both
you.
preterm, right? And so
Yes.
that level and that scope, Angela, you can go down a rabbit hole if you want to, but I do know that babies are prescribed different caloric, and when I say prescribed, I mean that it is
Prescribed, yes.
prescribed
Yes.
different caloric intake and values based on not just their weight, but also how well they're doing, how well their urine, their osmolality, what their kidneys are doing. And so that's a whole nother,
That's a whole
whew,
nother thing. Well, and
yeah,
also it's not just calories, right? It's also the metabolic needs of the newborn,
yeah.
and depending on that level of prematurity that they have. And so, so indeed, calories are just not a really complete descriptor of what an infant needs. So just
A preterm
FYI.
infant,
A
definitely.
preterm, as well
Yeah,
as even a term. I mean, a term infant, we're dealing. It's a lot more clear that it's based on the weight of the
yeah.
infant. But if there's been any sort of, intrauterine growth retardation or anything like that, then that or restriction, then that's an issue. So, okay, good. What other questions are here? I'm not seeing anything else. What am I missing?
I think, we need to change this to 2 hours, Angela. I mean, like the next time we do this, um,
I know. I did have it in my calendar for 2. I just think that
did you?
when we
Okay.
were scheduled, it was a little longer. So fortunately, we're recording this in case we lost some folks. Y'all can
Yeah.
watch it later, and I'm so glad that you are watching it later. Thank you so much for watching it. If you do have any questions, if you need the handout or anything, I know some people couldn't see the pictures on their phone. I'm so sorry, didn't realize that with the GoToWebinar, that it was challenging with the phone. Hopefully you can go back and watch it again, but you can always reach out to support@lactationtraining.com. And Wendy, Julie, Kim will tag us if there is a question that they can't answer. And so we're very happy to entertain any question.
I just want to just say, you know what? Congratulations on making it this far. The best thing to do is to determine what your areas of growth are right now. So notice that Angela didn't really have too many questions about positioning and latch, right? Um, it's the hope that those questions you have those, right? But when you think about pathology, when you think about endocrinology, when you think about development, whatever those areas are, try to focus on those. Um, Try not to focus on the information you know already. Questions, do questions, do questions, do questions. Continue to do your questions. And I think that's all I can offer.
Well, and I think also it's important to remember that, there is no one organization out there which has like the corner on the best exam prep or the best tool that you can practice and compare. And the reason why is, IBLCE is only 35, 40 years old. And so there's not a lot of their sample questions which are out there in the world. We are told that ours are are closely aligned as far as like how they're set up and everything else. So, I mean, we do get a lot of positive comments about our exam review content. And so indeed, we can speak to that best because frankly, Sekeita and I helped to develop some of it. And so please do take a look at some of the resources that we have, and hopefully some of the suggestions that we've provided to you today have given you just a little bit of peace so that you can focus where you need to study. So good luck to every
Yes.
single one of you. And you know, you've got this, you've got this, you've got this. Just keep breathing, you've got this.
Yes. It's all about the breath work, as Angela would tell me all the time. Sekeita, are you breathing?
That's it, y'all have to breathe. It's important. So yes, great. Well, thank you all very much for joining us today. This has been a great pleasure, and we will hopefully see you on the other side, and we'll hear from you in mid-December when you say, I passed. So
Listen, we want to
look
hear from
forward.
you all.
Yes,
Listen,
we do.
seriously,
We really
when
do.
you pass, we
When
want
you
to
pass.
hear.
When you
You
pass,
know,
yes.
and I'm not a I love for it to be evaluated and to be critiqued, and to make this better. um, Truly, we are here so that hoping that we can just provide some pearls for you to be successful. So when you are successful, we want to know.
We want to
So
know.
don't be shy, for real. Don't be shy.
No,
People
don't
are
end up
shocked
being
when they
shy.
email me and I get a response and they get a response and they're like, "Oh, you responded." Like, yeah, I said, email me, right?
We do respond. I mean, we've got customer support 7 days a week, right? And they will ping
Mhm.
us whenever something comes into support. They will ping us immediately. So indeed,
Yes,
do reach out to folks, and we look forward to hearing from you all. So thank you very much, everybody. Have a
absolutely.
great rest of your day, evening, morning. Thank you very much.
Thank you. Enjoy. Bye bye.
Bye bye.